Sir, we are live now. With all your permission, I am starting this session. Good afternoon, everyone present here. I welcome all the participants on today's session. Let's welcome today's speaker with great honor, Dr. Manish Bhatnagar, sir. Let me share some of the achievement of this sir. Sir has done MBBS, MD in General Medicine, DM in Gastroenterology, and FACG, MASGE, AGA consultant, gastroenterologist and hepatologist and therapeutic endoscopist, founder chairman of ICON Hospital, director and HOD of gastroenterology at Orchid Hospital, Medi Services. Today, sir is going to speak on a topic, management of acute pancreatitis. Let me tell you overview of the topic. Acute pancreatitis is a complex and a critical aspect of healthcare. This condition characterized by the sudden inflammation of the pancreas require immediate medical attention and multidisciplinary approach to alleviate pain and treat complication and prevent recurrence. In this session, sir is going to explain more about this topic. By taking not much time, I would like to invite sir and hand over this session to sir. Over to you, sir. Kindly proceed from there.
Thank you, Faraz, for that kind introduction, and good afternoon to all friends who have joined in. My mandate today is to talk about managing acute pancreatitis, which, as we all know, is a very serious and potentially fatal condition if not treated adequately. So please keep in mind that I'm not going to be discussing chronic pancreatitis, which is a separate entity and can be a sequelae of acute pancreatitis or a de novo disease in itself. And today my focus will be mainly acute pancreatitis. So whenever we talk about pancreatitis, I usually, just a second. I start my talks with this fairly disturbing looking painting. This is from a Russian artist Tchaikovsky, which is about a ship in a storm. And pancreatitis can very easily be likened to a ship in the storm, where the patient is the ship, the disease, which is pancreatitis, is the storm, and the physician is the captain. Now, whether this is the physician, surgeon, gastroenterologist, gastrosurgeon, whoever is treating, is basically the captain of this ship. And the job of that captain is to steer the ship out of the storm and into a clear port. And how do you do this? So if we look at the problem of pancreatitis, acute pancreatitis, the mortality can range from anywhere between 3 to 17%. And one has to differentiate between interstitial versus necrotizing pancreatitis. Please keep in mind that there are huge costs of treatment of severe pancreatitis, and incidence of acute pancreatitis varies between 4.9 and 73.4 cases per 1 lakh worldwide. However, we have seen that there is an increase in the annual incidence for acute pancreatitis, and this was reported from Dr. Singh's group and published in Clinical Gastroenterology and Hepatology way back in 2011 from the Institute of PGI Institute at Chandigarh. Now, when we talk about acute pancreatitis, how do you diagnose it? So from a simple clinical perspective, the diagnosis of acute pancreatitis requires at least 2 of these 3 features. One is to have abdominal pain, which is consistent with the diagnosis of acute pancreatitis. The serum lipase or amylase activity needs to be at least 3 times greater than the upper limit of normal. And there have to be characteristic findings of acute pancreatitis on CT and less commonly MRI or transabdominal sonography. When we talk about the etiology of acute pancreatitis, alcohol and gallstones dominate. There are other rare causes like hypercalcemia, hypertriglyceridemia, drugs, malignancy, developmental anomalies, and occasionally what is known as genetic predisposition to pancreatitis. Now, since we are all clinicians and we all know what pancreatitis is, I'll just talk about these basic new perspectives which have emerged in the last few years. One is the revised Atlanta definition, the clinical severity grading systems, initial management and resuscitation, nutritional support, antibiotic strategy, ERCPs in acute biliary pancreatitis, intra-abdominal hypertension or compartment syndrome, and interventions for infected necrosis will be the focus of my talk. So when we talk about management of acute pancreatitis, the first thing is you have to assess the severity. You have to decide whether the patient can be treated in a normal ward, which is the case if it is mild pancreatitis. But you need to keep re-evaluating that patient on a daily basis to identify patients who are likely to deteriorate or have a more severe course. Wherever you consider that there is the possibility of a severe course, the risk of severe course, or where there is existing organ failure, please admit these patients in an ICU. Now, once you have admitted this patient, comes the part of diagnostic workup. The diagnostic workup has to be focused on trying to identify the etiology and confirm or exclude biliary etiology, hypertriglyceridemia, or hypercalcemia. Do consider an early CT scan. Doing an early CT scan, if you have clinically significant clues for pancreatitis, is actually not very useful, because many times an early CT scan may not pick up the sequelae of acute pancreatitis, and therefore my clinical practice is to do it only after 48 hours, preferably after 72 hours. But wherever you have a diagnostic dilemma, there probably an early CT scan would help. Also monitor intra-abdominal pressure in severe pancreatitis, what is known as the compartment syndrome. Then one has to correct the hypovolemia and consider goal-directed fluid resuscitation. But very important, avoid fluid overload. I'll be speaking about this later in slightly greater detail, because when I was a student in gastroenterology 3 decades back, we were always told that give most of the fluid very fast over 24 hours. But concepts have evolved over the period of time, and we'll see that today the idea is to give goal-directed fluid resuscitation and avoiding fluid overload. One can consider an urgent ERCP in cases of cholangitis, when we are suspecting cholangitis to be the cause and gallstone pancreatitis to be the reason. Doing an urgent ERCP and cleaning the CBD and draining the CBD with a stent is something which will help the patient recover much faster. One must start oral feeding as soon as it is tolerated, and it is always better to prefer enteral over parenteral nutrition. Use antibiotics only in cases of suspected infection, and consider drainage of infective necrosis. So this is basically in a nutshell what one needs to do in the management of acute pancreatitis, starting with the assessment of severity, admission, diagnostic workup, and then finally treatment based on the severity and the clinical symptom. So if you look at the classification of acute pancreatitis, this was the Atlanta revision, which happened in 2013. There are 2 types of pancreatitis which are now recognized. Interstitial edematous acute pancreatitis, which is characterized by acute inflammation of pancreatic parenchyma and peripancreatic tissues, but it has no recognizable tissue necrosis. The second is necrotizing acute pancreatitis, which is characterized by inflammation associated with pancreatic parenchyma necrosis and or peripancreatic necrosis. So you have interstitial edema without necrosis, and then you have necrotizing acute pancreatitis, which is self-explanatory that it has the presence of necrosis. Now, if we talk about the grades of severity, mild acute pancreatitis is having an absence of organ failure, and there are no local or systemic complications. In moderately severe acute pancreatitis, there is organ failure, which is transient and that resolves within 48 hours. And or local or systemic complications are there without persistent organ failure. Then comes the most terrifying variant, which is the severe acute pancreatitis. This is persistent organ failure which lasts more than 48 hours. There is single organ failure, or there can be multiple organ failure. And there is associated morbidity and mortality, which is much higher with severe acute pancreatitis than with moderate or mild acute pancreatitis. So if we look at the revised definitions, you have the interstitial edematous pancreatitis, where there is acute inflammation without recognizable tissue necrosis. And then there are the CT criteria, the pancreatic parenchyma enhancement by IV contrast agent, and no findings of peripancreatic necrosis. Similarly, inflammation associated with parenchymal necrosis falls in the ambit of necrotizing pancreatitis, And in CT, we see lack of pancreatic parenchymal enhancement and presence of findings of peripancreatic necrosis. The CT cuts on the right do depict that. I'm not going into too many details of that. Then comes the entity of APFC, also known as acute peripancreatic fluid collection. Now, this is seen within 4 weeks after onset of acute pancreatitis and is without a pseudocyst. The CT criteria, it occurs in setting of interstitial edematous pancreatitis. It's a homogeneous collection with fluid density. It is confined by normal facial planes. There is no definable wall, and it is adjacent to the pancreas. Then we all know the entity of pancreatic pseudocyst. This is an encapsulated collection of fluid with a well-defined inflammatory mass wall outside the pancreas with minimal or no necrosis. Occurs usually after 4 weeks of acute onset. On CT, it is a well-circumscribed homogeneous fluid density with a well-defined wall which is completely encapsulated, and maturation usually requires more than 4 weeks after onset of acute pancreatitis and occurs after interstitial edematous pancreatitis. The other entity we deal with is acute necrotic collection. This is a collection containing variable amounts of both fluid and necrosis associated with necrotizing pancreatitis, and this necrosis can involve peripancreatic parenchyma and or peripancreatic tissues. In CT, you will see it in setting of ANP with heterogeneity and non-liquid density. There is no definable wall, and the location can be intrapancreatic or extrapancreatic. Then comes the entity of walled-off pancreatic necrosis, WOPN. This is a mature encapsulated collection of pancreatic and or peripancreatic necrosis that has developed a well-defined inflammatory wall. Again, this occurs more than 4 weeks after onset of acute necrotizing pancreatitis. The CT criteria show heterogeneity with liquid and non-liquid density of various degrees of loculated collections. It has a well-defined wall, and the location can be intrapancreatic and or extrapancreatic. So, having told you about these various classifications and the entities which arise out of severe acute pancreatitis and acute pancreatitis, we now look at the assessment of severity. So, first thing to look at is patient characteristics, whether the age is more or less than 55 years. These are bad prognostic features. If the patient is obese with a BMI of more than 30, if the patient has altered mental status and there is presence of comorbid disease, these patient characteristics are considered bad in terms of prognosis. Then there is the systematic inflammatory response syndrome known as SIRS, which is defined by the presence of more than 2 of the following criteria. Tachycardia, that is a pulse more than 90 per minute. Tachypnea, which is respiratory rate more than 20 per minute, or a PCO2, which is in excess of 32 millimeters of mercury. Temperature, which is fever, which is more than 38 degrees centigrade, or hypothermia of less than 36 degree. And WBC count, which is more than 12,000 or which falls to less than 4,000, or has more than 10% immature neutrophils in the form of bands. So if you have more than 2 of these following criteria, the diagnosis of SIRS is made, and these patients have a very tumultuous course which can even be fatal. Now, there are a few laboratory findings which help us in assessing severity. These laboratory findings are BUN, which should be more than 20. A rising BUN has a bad prognostic value, a hemoconcentration more than 44%, a rising HCT, and an elevated creatinine. Radiologically, if you find the presence of pleural effusions, pulmonary infiltrates, multiple or extensive extrapancreatic collections, that is very severe disease. For grading severity, we have used various systems in the past, like the Apache 2, Ranson, and modified Glasgow score. There have been single serum markers like CRP, hematocrit, procalcitonin, and BUN. However, what we know is that none of these are clearly superior or inferior to the presence of persistent SIRS, which has now been rated as one of the most prognostically accurate and significant tools to be used for deciding severity of pancreatitis. So SIRS is advised to predict severe acute pancreatitis at admission, and persistent SIRS at 48 hours carries obviously a much higher morbidity and mortality. Persistent SIRS is associated with multi-organ failure and mortality. It is also associated with a mortality of 25% compared with 8% for transient SIRS. Sensitivity of persistent SIRS for mortality is 77 to 89% and specificity is 79 to 86. SIRS at admission for prognosis is nearly 100% and the sensitivity is 100% and specificity is 31%. So how do you decide which patient goes to the ICU? So the patients who have a pulse less than 40 or greater than 150 beats per minute, patients who are in hypotension, like with a systemic arterial pressure of less than 80 millimeters of mercury, or who have a diastolic arterial pressure which is greater than 120, those who are tachypneic, who have more than 35 breaths per minute, those who have hyponatremia or hypernatremia, hypokalemia or hyperkalemia, those who have an oxygen saturation of less than 50 millimeters of mercury with a pH which is less than 7.1 or greater than 7.7, those who have significant hyperglycemia in terms of serum glucose raised beyond 800 milligrams per deciliter, hypercalcemia, anuria or coma, these are patients who definitely require ICU admission. Now, when we talk about fluid resuscitation, that is the first thing we do apart from pain relief in patients with acute pancreatitis. So these patients have hypovolemia, which is due to vomiting, reduced intake, third spacing, respiratory losses, and diaphoresis. There is micro and microcirculatory dysfunction. The markers of hydration need to be clinical, rising BUN, hematocrit, and CVP, and modest increase of BUN is associated with increased risk of death. Normal BUN, which does not increase, the risk is less than 1%. So it is very important to quantify these prognostic factors initially itself. Initial 6 to 12 hours of resuscitation always affects the outcome, and it has been found that the choice of fluid needs to be ringer lactate, which reduces SIRS vis-a-vis saline. So the dose is usually 250 to 500 ml per hour or 20 milliliters per kg bolus, followed by 1.5 ml per kg per hour. Reassess these goals and dose every 6 hours based on the urinary output and the CVP of these patients. So when we talk about nutritional support, I have initially also said we always prefer enteral nutrition over parenteral. Feeding should be started early in patients with mild pancreatitis. Please initiate with a low-fat solid diet, which is as safe as a liquid diet. You can give nasogastric versus nasojejunal feeding. Both are equally good. Continuous slow feeding instead of bolus feeding. There is no role for probiotic supplements or glutamine, and I personally do not recommend the use of antioxidant supplements. When will you do an ERCP in acute biliary pancreatitis? I will do an ERCP in a patient with acute pancreatitis if there is concurrent cholangitis and where there is a gallstone acute pancreatitis where there is no evidence of ongoing biliary obstruction. I will avoid doing an early ERCP. I will even look to do an MRCP or an EUS if I'm suspecting CBD stones, and a pancreatic duct stenting and or post-procedure rectal diclofenac is used to reduce the risk of post-ERCP pancreatitis. Please keep in mind these are very sick patients, and ERCP should be done at a center by somebody who is an expert in this thing, and this is really not for the faint-hearted gastroenterologist to do an ERCP in a patient with acute pancreatitis. Now, antibiotics should be used on pneumonia. Routine prophylaxis with antibiotics is not recommended in severe acute pancreatitis. Similarly, routine use of antifungals with antibiotics is not recommended, and use of antibiotics to prevent infection of sterile necrosis is also not recommended. However, you have to consider it infected necrosis if there is deterioration or failure to improve in 7 to 10 days. A CT-FNA or empirical antibiotic therapy may then be tried out, and the preferred antibiotics in cases of pancreatitis are carbapenems, quinolones, and metronidazole. A word about abdominal compartment syndrome. ACS is sustained intra-abdominal pressure more than 20 millimeters of mercury with or without abdominal arterial perfusion pressure, which is less than 60 mm of mercury and is associated with new onset organ failure. ACS can result in renal failure, hypotension, colonic and small bowel ischemia leading to gangrene. So recognition and treatment of abdominal compartment syndrome is an absolute must in cases of severe acute pancreatitis. So if you have IAH, it is an ongoing or repeated pathological increase in intra-abdominal pressure, which is more than 12 mm. And in 60 to 80% of patients with severe AP, not all will develop acute compartment syndrome, but 60 to 80% will. So IH is graded as follows. Grade 1 is 12 to 15 mm of mercury intra-abdominal pressure. 16 to 20 is grade 2, 21 to 25 is grade 3, and more than 25 millimeters of mercury is grade 4. Mortality in ACS is 47% versus 11% without ACS. So this is a powerful prognostic tool, and one must be aware of this. So how do you go about treating ACS? Medical interventions to decrease IAP are to maintain abdominal perfusion pressure above 60 millimeters of mercury. Hollow viscera volume can be reduced by doing nasogastric drainage and using prokinetics and rectal tubes, and occasionally endoscopic decompression. Intra and extravascular fluid volume resuscitation should be on demand, and if the patient is volume overloaded, please use diuretics and occasionally ultrafiltration. Abdominal wall expansion with adequate analgesia and sedation to decrease abdominal muscular tone, and neuromuscular blockade if necessary. And lastly, as a last resort, surgical decompression with laparotomy and temporary abdominal closure is the last resort in patients with intractable ACS. So what are the complications of acute pancreatitis? We've already discussed necrosis, which can be either sterile or infected. It can be a pseudocyst, which is a collection. It can be a walled-off pancreatic necrosis, which is debris and fluid, which is encapsulated. There can be duct disruption and fistulae leading to pancreatic ascites and pleural effusion, and you can have the disconnected duct syndrome. The therapy will range from endoscopic procedures to EUS-guided procedures with minimally invasive surgery, and occasionally percutaneous drainage where the patient is not fit for any of these interventions. So in management of pancreatic necrosis, one should only intervene when there is clinical deterioration. Try to delay the intervention as much as possible. Up to 4 weeks is ideal. Early intervention has to be done if there is worsening multi-organ failure, and mortality of open surgery is 75% if done within 2 weeks. It is less than 20% if done later than 4 weeks. The figures speak for themselves. It is better to delay drainage of pancreatic necrosis for 4 weeks or so. When we talk about pancreatic necrosis, like I said, it can be sterile or infected. Surgery was earlier considered the only option. However, we now know that conservative therapy can succeed in over 50% of the patients. How do you diagnose infected necrosis? Clinically, it is through fever, organ failure, presence of leukocytosis. A very powerful tool is procalcitonin. I personally do not rely on CRP, which is an acute phase reactant, which is bound to be raised in any patient with acute pancreatitis. But if my patient has a raised procalcitonin with a rising chance of severe acute pancreatitis, multi-organ failure, I would consider that as a sign to go in and to be more aggressive. CTFNA through gram stain and culture is mandatory in such cases, and percutaneous drainage occasionally can buy you time and help to stabilize the patient. So this is a busy slide talking about what it needs to be done in the case of pancreatic necrosis. If the patient has an infected pancreatic necrosis, one can give empiric antibiotics. If the patient doesn't improve, you have to assume it is infected necrosis. If patient is unstable, go immediately for surgery. If the patient is stable, continue antibiotics, observe, use minimally invasive therapy, and if asymptomatic, do not go for debridement. However, if one finds on CT, FNA or gram stain that it is negative, then this is sterile necrosis and one needs to continue conservative treatment and repeat FNA every week. Only if the FNA comes positive would you need to intervene in terms of debridement or surgery. There are other minimally invasive ways of treating pancreatic necrosis, which are laparoscopic surgery, either percutaneous or radiological catheter drainage, video-assisted small incision-based retroperitoneal debridement, endoscopic necrosectomy, which is what people like me do who are therapeutic endoscopists, and a combined modality treatment. With these things, we can avoid surgery in about half of the patients. And there have been multiple RCTs, and the meta-analysis is that one should use a step-up approach where there is less cost, less new onset organ failure, and lesser surgical complications if we are a little conservative in managing these things. So this is a CT scan of a CT-guided percutaneous drainage. You can see the catheter has been placed in the necrotic area, and this is the theory of the whole thing. So these are minimally invasive ways of draining these collections which can be infected. These are pictures of a few of these stents, which we call lumen opposing metal stents. You can actually see the stents have opened out beautifully, and this is helped by the modality of endoscopic ultrasonography, and it helps us to remove the debris and clean out the walled off pancreatic necrosis. There are various stents which are available. As you can see, this is a stent which is known as a LAMS, which is the lumen opposing metal stent. And of course, you have these multiple stents coming out through the ampulla of Vater, which are draining the CBD and the pancreatic duct. So minimally invasive therapy has now become the norm. Organization of necrosis is a basic prerequisite. Pseudocysts and walled off pancreatic necrosis develop anyways after 4 weeks only. Management has to be customized. Institutional expertise and availability of technology should be considered, and an early referral to Center of Excellence is recommended. So summing up, the management of complications, you use antibiotics where carbapenems remain the first choice. You use procalcitonin for guidance when antibiotic therapy is considered to reduce unnecessary antibiotic use. For infected drainage, necrosis, drainage of infection of the necrotic collection should be delayed and treated with antibiotics alone if possible. And the modality of drainage can be either percutaneous, transgastric, or lumen opposing. Intra-abdominal hypertension, neostigmine treatment can be considered. Biliary necrotizing pancreatitis patients have to be closely monitored and have to undergo a cholecystectomy once the collections have resolved. Persistent organ failure, we have to consider removal of cytokines as last resort for persistent organ failure. These patients may require things like dialysis, SLED, and even MARS. So summing up, on admission in week 1, you do the diagnosis through laboratory tests, USG, CT if required. You prognosticate the patient in the first 24 hours through the BUN, the SIRS, the CREATE. The treatment is then based on fluid resuscitation, nutritional support if needed, culture-guided antibiotics, and an ERCP as and when needed. In weeks 2 and 3, one goes for a CT or an MRI to look for pancreatic necrosis or collections. If there's clinical deterioration and positive FNA culture, go for percute drainage. If the patient is stable at 4 or 6 weeks, continue conservative medical treatment. If the patient is deteriorating or showing signs of infection or positive FNA culture, do a percute or endoscopic drainage. In the absence of improvement in spite of drainage, one has to go for necrosectomy, which can be either endoscopic or surgical. It can be minimally invasive or through laparotomy, and repeat the procedure if necessary. At the end of 6 weeks, if there's mechanical obstruction or failure to thrive, again, you would go back to the percute route or necrosectomy. And finally, you have to do a cholecystectomy after resolution of local symptoms when it is due to biliary pancreatitis, that is to say, gallstone cyst. So if I wanted to tell you about the key points as per this presentation, there is now a new nomenclature as per the revised Atlanta classification, which we discussed. There is a risk stratification, which we have already discussed. I would like to stress here that these days we like to give less fluid rather than more, and less is better. And it has to be a situation where the patient is not volume overloaded. Antibiotic and nutrition support strategy is a must. You must time your intervention, whether it is ERCP, minimally invasive surgery, or laparoscopy, and a step-up approach and individualized therapy is something which is an absolute must. So moderate compared to aggressive fluid resuscitation. Always keep in mind, use ringer lactate. Diet has to be resumed on demand. Delayed drainage. Infected necrosis can be treated only with antibiotics in substantial proportion. And strategies to prevent or mitigate early organ failure are still lacking. So to summarize, the recommendations based on recent literature, early management fluids, administer a moderate fluid resuscitation. And by moderate, earlier we used to do 20 ml to 25 ml per kg bolus. Now we do 10 ml per kg bolus in cases of hypovolemia and follow it up with 1.5 ml instead of the 2 and 3 ml per kg hour, which we used to do. Use ringer lactate. Resume diet on demand as soon as it is tolerated. Please provide pain management to your patient, which combines either paracetamol, metamizole, simple opiates, and consider epidural analgesia where required. Prophylactic antibiotics, pre and pro and postbiotics are just not recommended. Use antibiotics only where there is evidence of infection and necrosis, which is infected. There's no role for antibiotics in sterile necrosis. And if you keep these things, now this is the second part of the painting by the same painter. And now you see that the ship, which was being tossed around in a very turbulent sea, has entered a quiet port, and there was no loss of life or material to the ship. And that's exactly the role of us as clinicians when we see these patients of acute pancreatitis. Thank you very much, and it will be my pleasure to take any questions.
Thank you so much, sir, for giving your valuable time and sharing your knowledge with us and making this session informative one. I definitely think this session knowledge is going to help all the participants on their practice also. Sir, I can see, sir, we have received some questions. Sir, if you allow, with all your permission, shall we take these questions?
Yes, please go ahead.
Okay, sir. First question I can see from Dr. Rohini. She is asking, what is the role of abdominal trauma or injury in the development of acute pancreatitis?
Yeah, Dr. Rohini, that's a very good question, and thank you for that. And a blunt abdominal trauma, specifically steering wheel injury into the abdomen, is now recognized as one of the most common reasons for traumatic pancreatitis, as we call it. And it can lead to either duct disruption, it can lead to pancreatitis, which is no different from any other pancreatitis. And that is why a history of trauma, or what is also important is many times to ask for drug history. And traumatic history does not always have to be very significant trauma. Many times we have had pancreatitis patients presenting to us with probably a cricket ball injury. And we found that it was traumatic pancreatitis. So that's a very good question. And I think we need to keep the history of trauma in mind whenever we see a patient who presents to us with no other factor except trauma leading up to pancreatitis.
Thank you so much, sir, for explaining it, sir. And Dr. Rohini is also writing, thank you so much, sir, for this wonderful presentation.
My pleasure.
Yeah, and sir, moving forward, I can see another question from Dr. Agarwal. He's asking, what causes of hyperglycemia maybe lead to acute pancreatitis?
Hypercalcemia, Dr. Agarwal, can be either due to hereditary hypercalcemia. The patient might have a parathyroid adenoma. And of course, there are genetic conditions which predispose one to hyperglycemia. But basically, in my practice, what concerns me more often, and which we pick up when we do a sonography of the neck, are parathyroid adenomas, which are a known cause of hypercalcemia. Usually, when patients have acute necrotizing pancreatitis or even acute pancreatitis, there is a situation of hypocalcemia because there is an element of saponification, which happens whenever the pancreatic juices come out of the pancreas. So in any patient with acute severe pancreatitis who has normal calcium or has high calcium, please do look at hypercalcemia as one of the main etiological factors for leading up to this. And doing a simple sonography of the neck might help you to pick up a parathyroid adenoma. In cases where you have a strong suspicion that the patient has hypercalcemia and there are no other reasons for that, one can go for a CT scan. And many times we have had very gratifying results because just operating on these patients and removing that parathyroid adenoma will cure them of hypercalcemia and the resultant episodes of pancreatitis, which are bound to follow if the hypercalcemia is not treated.
Thank you so much, sir, for explaining it, sir. We will be taking last question for today's session, which is from Dr. Subramaniam. He is asking, does an elevated BUN level at admission indicate increased severity of acute pancreatitis?
Yes, of course. A high BUN has a bad prognostic value, but what is more important is that whatever is the value at admission, if your BUN continues to rise, that is a very bad prognostic. So yes, definitely a high BUN is a bad prognostic sign, but more important is the serial rise of BUN post-admission, because that tells you that the patient is deteriorating and is likely going for multi-organ failure.
Okay, thank you so much, sir, for answering all the questions, sir. And one doctor, Shivam Bharadwaj is writing, sir, a wonderful session and great to have this presentation with you.
Thank you, sir.
And I think he has really enjoyed this session, sir. As there is no more questions, sir, from the participants, sir, with all your permission, shall we conclude this session, sir, if you allow?
Yes, absolutely.
Okay, thank you so much, sir, for you taking out your precious time and making this session informative, sir. Hope to see you again with different topic in future, sir.